Hello, I'm Dipti Itchhaporia, and welcome to another podcast for Radcliffe Cardiology. And today I'm really honored to have Dr. Michael Gibson, who is an interventional cardiologist, a cardiovascular researcher, an educator, and really an innovator. And today we're going to talk about innovation in cardiovascular research and just innovation in general in cardiology. So welcome, Michael. I'm so happy to have you here.
Thanks for having me on your show.
Great. So let's launch into it. As I said, you're such an innovator, and you do a lot of clinical research. You're the CEO of the Baim Institute for Clinical Research. Tell me about the innovative things that you're doing in terms of clinical research.
Well, we have to change. We can't afford to spend $1 billion every time we want to evaluate a new drug or device. So we are trying to do things much more efficiently. I think the goals are to do things cheaply, quickly, and with good quality. How can we do that? Well, what we're doing is going more towards direct to patient trials, cutting out some of the bricks and mortar, going directly to the patient and bringing the trial to the patient rather than waiting on the patient to come to the trial. So let me give you an example. Say in the Apple Heart Study, where we are comparing an Apple Watch to no Apple Watch to detect AF, we approached 380 million people and randomized 34,000 people over the internet, no bricks and mortar, doing the study at 1% of the cost, getting follow-up directly with the patient using electronic patient-reported outcomes, or ePROs, and then using the claims database to see, are you dead, alive, did you have a stroke or bleeding? So I think this is one way we can do things quickly at a lower cost, but preserve quality. We have published several papers comparing claims databases to see what happened to patients versus, using the old way of having doctors adjudicate the events. And overall, the results are very, very similar. So I think that's the way things are going in randomized trials. I'll say this week, we are launching a massive 1 million patient registry, moving up to 5 million patients in the cardiometabolic space. It'll again be a direct to patient approach. We'll be collecting every kind of omics with home blood testing, bringing the study to the patient in their home. We'll, of course, be collecting their demographics as well.
So let me ask you, how do you do this though? How do you go directly to the patients? How do you involve the patients?
Yeah, I mean, every 90-some percent, 95% of people have, one of these. They have cell phones and the internet. I think, people talk about the digital divide, but I don't think that's as big of a barrier as people think. I think the bigger divide is getting into the hospital, paying $40 for parking and taking time off work and all of that. So yes, there is a digital divide, but I think we're finding when you approach vast numbers of people, you can also get vast numbers of people to participate. I'll also say we'll be collecting zip code information, which people agree to. You are your zip code in terms of your health. And I know you're a big advocate of this as well. We'll be looking a lot at the social determinants of health. And this kind of registry will also perform the backbone of randomized trials. So rather than having to, again, go to the bricks and mortar and all of that, we'll be going direct to patient to identify who are the right people with the right modifiable risk, with the highest event rates that we want to enroll in trials.
But how do you get these patients to actually look? So if you put the trial up on the phone, how are they getting to that? I mean, how are you pushing out the information, and how do you know the patients to push the information out to? Again, I know you mentioned the digital divide, but again, if you're interested in zip codes, there may be zip codes where, the broadband may not be good. Patients may not have, a smartphone. Even if they have a smartphone, I mean, there's a lot of barriers, right? So I'm just wondering, how do you target those patients?
Yeah, well, you can oversample those kinds of patients. So when we go to 380 million patients, we do it through social media, through advertising, through print media, as well as electronic media. I get on TV and do TV shows throughout the country. So it's a multi-pronged approach, but you can oversample patients by going to AARP or Society of Black Cardiologists, or any of these interest groups, and oversample those kinds of patients. It's not perfect. It's not perfect. Nothing's perfect.
No, I think it's great. Let me go back to the Apple Heart Study. If you had to say what was the best thing about the Apple Heart Study, and maybe you've already said it, what do you think was the best thing about the Apple Heart Study?
I think the best thing about this study, by the way, called the Heartline Study, is not necessarily the result of the study, but the idea that we can implement something like this, that we can do randomized trials at 1% of the usual cost. I think the main cost of the study was the patient acquisition cost, but I think it's more of a new path forward rather than the result of any study. We learned a lot about crazy things. What are the best ways to find patients in terms of the name and the content in the subject line? What do they respond to in terms of graphics on the page in the email? So we're learning a lot about how do you engage patients? And I think those are going to be the more durable lessons for this as a process moving forward. I'll also say we have a lot of work to do on long-term follow-up of patients. You know this, 5 years later, 10 years later, we don't know what happened to all those people who have a new valve or a stent. We've now built at Baim a platform where we can follow people for, say, 20 years by touching them regularly through, we'll send you a text. If you don't respond to that, we'll send you an email. If you don't respond to that, there's your second email. You don't respond to that, there's your family member 1, family member 2, then your doctor. So we're developing ways where we can get that long-term follow-up that we need by more of a direct-to-patient approach.
Going back to that Apple Heart Study, there were a lot of good things that came out of it. Now I know it's the Heartline Study, but why didn't it take off? Why didn't, the original results, why hasn't it been more permeated through regular clinical use? What's your thought?
Yeah, I think that study, the original Apple Heart Study, enrolled everybody of all ages. And it was fascinating. You had young people enrolled too, but contrary to what you might have thought, the young people weren't compliant. When something happened, they didn't get the patch to see if they had AFib. They didn't follow up. Contrary to what you might have thought, or paradoxically, it's the old people over, say, age 65 who were more compliant and really, participated meaningfully. So in Heartline, everyone's over 65. We thought, oh my gosh, these elderly people, they're not going to engage with the app, and this is going to be a disaster. It turned out to be the opposite. I mean, we have 90% of the time they're completing all of these electronic patient reported outcomes. We're talking about things about sleep, anxiety, a diet, exercise, depression. So as an example, we're publishing a study we did about depression and anxiety during COVID by age and gender. So part of the result is about atrial fibrillation. But for every atrial fibrillation piece of data, there's like 10 more other pieces of data about, how people are feeling and their quality of life and all that. So it's fascinating. Really, the older patients were much more engaged. We also learned a lot about how do you engage people? And it's not enough just to say you have an app. What we did is twice a week, we provided them with legitimate health information. And they really liked that. they're counting on us, and this, they're counting on us to kind of be the DJ for them of, what's important out there. There's so much information. People want us as healthcare providers to help curate that information. They're hungry for that. So I found that the way you really kind of keep them engaged is with once a week, twice a week, kind of snippets of stuff that they can trust. And it goes back to trust, right? That's what we've got to reestablish, is the trust of our patients, that we have their best interest in mind and are serving up credible information to them.
So in your experience, what do you think is the future of digital tools for clinical research going forward?
I think it'll be a hybrid model. You can't get rid of all the bricks and mortar. I think, though, you will see more and more of it being done virtually. We have better and better ways to ship drugs to people's houses. Rather than coming to the hospital, you may see models where there's a testing city in their testing center in their city. I think the future, though, is not a fixed bricks and mortar center, but a mobile unit going to the patient, particularly in those underserved areas that you're talking about. You got to bring the research to the patient if you want to be successful. I think we've only seen the very tip of the iceberg in terms of wearable. I'm working with some companies like Bina AI. You put the phone in front of your face, it gives pulse, blood pressure, oxygen saturation, cardiac output. But get this, now with their technology, by shining in certain wavelengths of light and looking at the reflectance back, they get cholesterol, they get hemoglobin A1C, leukocyte count, lymphocyte count. I mean, the world is going to change. We're going to be moving those kinds of assessments right to the patient so that we can monitor them in real time. So I think more virtual, less bricks and mortar, bringing everything to the patient.
So I have two thoughts. One is, when you do all of the, the calling and all of that, it's taking up a lot of labor. I mean, so is that going to offset some of the cost savings that you have with bricks and mortar? So, that's just a thought, and you can comment on that. And then let me just make one other point about, I know you're really interested in implementation science. And so when you get all this information, one of the reasons that we really haven't had the true digital transformation of healthcare is that we've got pockets of data, but we don't have enough credible data the way that we like to be able to move the needle. Are we close to that, getting close to that? Where are we with that?
Yeah, well, on the first question, we're trying to minimize the calls. What we're doing is we're having the patient click on boxes, collecting structured data directly by the patient. Is it accurate? Maybe not completely accurate, but is it unbiased? Probably. And, it's better to have vast sums of data, collected in that way than missing data. We talk about, we have plenty of data, but data doesn't mean you've changed things. We keep doing these quote implementation science studies where we say, yeah, we're horrible at meeting our targets. We just keep saying we're horrible. So we've got to change things. That's why this registry we're launching called PARC, the Patient Activation Research Community, we've got to get to activation. So what we're focusing on in the lipid space is know your number. That's the first kind of activation. Rather than having to come in and get it checked, we're going to send you a home testing kit, number one. Number two, once you know that number, why aren't you following up with your doc? So we just completed a survey of 1,200 patients looking at, what are the barriers to getting tested, number one? What are the barriers, once you know your number, to getting in and getting something done? And number three, why didn't you get treated? What were the barriers to acting? So we've got to first, and we've done the survey, we're going to be publishing it, so we know the barriers. But now you're absolutely right. We've got to stop saying we're not doing well. We've got to change things and do better. And that's the focus, is on activation. How do you activate change? That's what we've got to focus on.
So it sounds like from an innovative standpoint for clinical research, you're going more out to directly to the patients. You're using digital devices. You're thinking about the implementation sciences. Anything else when you look into the future in terms of innovative approaches to all of this?
Well, one of the other things that I think is important is doctors, for years, we've been kind of collecting data about populations and making decisions based upon population results. You have a central tendency for a population that something worked. We don't really take care of populations. We really take care of individual patients. A patient really wants to know, is this a good choice for me? And that's where I do think, and we're working on this, the use of AI, which I think is a bit overhyped. But here's what we're doing. Let me give you an example. A patient wants to know from all that data, is this good for me? They not only want to know that, but they also want to say, here's how I care, what I care about. How do I rank death versus a stroke versus a heart attack versus a bleeding event? And, we have those measurements for populations. Generally a death's a 1, a stroke is about a 1, an MI is 0.7, bleeding is 0.3. That's nice. But what about you as a patient? What about you as a patient?
Right.
How do you rank those? So we've developed apps that allow you to say, here's how important I think all these different outcomes are. We then layer that on top of tens of thousands of patients from randomized trials and the result. And we tell you, here's the different doses of a medicine. And here is, how you can maximize the outcomes you want. How you rank those different outcomes. The other thing I think we've done poorly in terms of risk assessment is somehow we think at the beginning of the study or registry, we're going to predict what happens 1 year later. But that's not what we do in doctoring. We see someone every few months. And you and I both know our assessment of risk changes over time because that patient tolerated the medicine. They've declared they're not a bleeder. So, that informs our decision-making moving forward. So with our AI approaches, we're using iterative decision-making, seeing how you're doing over time to make shorter-term predictions, which I think are probably more accurate, and integrating your patient preferences about what you want to achieve. So I think it needs to be personalized, take into account the outcomes the patient wants to achieve. It needs to be iterative. That's where I see things going.
So, Mike, they always say innovation takes a period of time, right? That usually it's at least a decade. When do you think what you're saying is going to be mainstream? That's really the approach that we have. Do you think we're talking 5 years, 10 years? What do you think is the timeline?
I think what we've learned over decades is it's about a 10% per year battle to get a drug introduced into the market. This is different, though. This is, for what I'm talking about, is information to inform decision-making. I'm hopeful that the rate of introduction of that will be more rapid. I can't give you a number. I would hope that we might achieve 20 to 30% penetration per year. People are hungry for this. They're hungry to know what is good for them. The other thing they're hungry for is, I want that weight loss drug, but I can't get it. They want better, you talk about activation, they also want access. And as much as it drives us crazy, as much as it drives all of us crazy, you're going to see more and more direct to consumer telehealth approaches to give people the access that they want. So with better access and better activation, with all these new tools, I'm hoping we speed things up to more of a 20 to 30% per year adoption.
Yeah, I think this is fascinating. I do believe that this is a direction we're going in. So I want to bring it back to your Heartline study. When do we expect to see the results?
2025. Primary question is, can the watch detect atrial fibrillation? It's a time to first event analysis, not just the frequency with which we detect AFib, but how early do we detect it? So think of a KM curve. That's the first question as a proof of concept. I feel pretty good about that kind of question. I think we're adequately powered to answer that question. The second question is, does that change outcomes? Does that early detection, does it reduce your risk of stroke? We're allowing the doctors to engage in their usual management in terms of you choose what you want in terms of anticoagulant and everything. Does that improve outcomes? That's the second question. And there we're looking at hard outcomes like death, stroke, rehospitalization, things like that. So we'll see, does the detection of asymptomatic AFib, yes, we probably can do it, but does it improve outcomes? We'll see. We'll have 34,000 patients to test the hypothesis. It's going to be interesting.
Yeah, thank you so much. So this has been a fascinating conversation. I look forward to future conversations about where some of the stuff that we talked about is really coming out. But I think this is a fast-moving area. Really happy to have you be involved in giving us this update on what's happening innovatively in the clinical research space. So thank you so much, Dr. Gibson, and thank you to our audience for listening.
Thanks for having me on.